It's long been known that there are deep racial divides in breast cancer outcomes. And although the good news is that breast cancer mortality rates have declined by about 40% over the last 30 or so years, there continue to be disparities in outcomes for Black compared with white women. Much of this has been attributed to lack of access to care, insurance status, and other factors that have been broadly classified as social determinants of health. What we've tried to do in addressing that is examine clinical trial populations who have access to care, who are getting the best available therapy, and where that therapy is being monitored. When we evaluated outcomes in the TAILORx trial, a trial that included women with estrogen receptor positive, lymph node negative breast cancer, who had the 21-gene recurrence score assay used to guide the administration of adjuvant chemotherapy, we found that despite the fact that the Black women had comparable clinical presentation, comparable recurrence score, comparable treatment, they had worse outcomes. We also found in a more recent updated analysis of that the recurrences tend to be early, within 5 years. At this meeting, we heard data from the RxPONDER trial, a very similar trial evaluating the clinical utility of the 21-gene recurrence score in patients with 1 to 3 positive axillary nodes in cancers that were estrogen receptor positive and HER2 negative, where patients were randomized to receive chemotherapy or not. In that study, there was also seen racial disparities. Black women had higher recurrence rates overall, and in fact, the likelihood of having a distant recurrence was up to 70% higher in Black women compared with white women. After adjustment for other factors, clinical factors, such as obesity, that effect was attenuated, but there still seem to be disparities. We also saw another presentation at this meeting which attempted to try and identify what biological factors, if any, could be contributing to these disparities. And investigators, scientists from the Albert Einstein College of Medicine and Montefiore Medical Center, and a group of institutions from the New York City area evaluated a novel biomarker called TMEM, which is an acronym that stands for tumor microenvironment of metastasis. What this is, it's a microanatomic structure that represents where 3 cells are in direct contact, a subpopulation of tumor cells that express MENA protein, a motility protein that allows the cells to travel to a blood vessel. The second cell is a blood vessel and an endothelial cell, and the third cell is a macrophage. And where these 3 cells are in direct stable contact has been identified as a TMEM, so-called TMEM structure. It's been shown in both the laboratory and in the clinic that the TMEM density correlates with higher risk of metastasis. And it's also been shown in animal models that the TMEM site is where cancer cells intravasate into the circulation and therefore spread to other organs. In this particular study, what the investigators found was that they evaluated patients who had received neoadjuvant chemotherapy for localized breast cancer and looked at the TMEM density in the residual cancer. And they found that the Black women had higher TMEM density scores than white women and also had a higher risk of recurrence. And this was possibly driving that recurrence risk. This is very consistent with previous studies showing that TMEM density in the primary tumor in patients who did not receive neoadjuvant chemotherapy was also associated with increased recurrence risk. By understanding this potential mechanism that may be driving metastasis, we may be able to develop specific therapeutics that can block that step in metastasis.